Welcome to my presentation about prophylactic medications. And I would like to say that I have no disclosures to declare. And I jump over this slide as I have already been introduced to the audience. And I would like to give you a short overview about my presentation. I give you a short introduction, then I will talk about side effects of chemotherapy. Then I would like to show you some risk factors for GVHD and infections, and the principles of prophylaxis in GVHD and infections and the nursing implications. The photos that you see within my presentations are made by myself. They are from the ward where I've been worked before. So why do patients with stem cell transplantation need prophylaxis? They get high-dose chemotherapy for conditioning before transplantation, and the chemotherapy can be myeloablative, for example, with a combination of busulfan, cyclophosphamide, and melphalan, or non-myeloablative when we combine fludarabine, cyclophosphamide, and ATG. And the third version is a reduced intensity chemotherapy for patients who are at high risk for developing complications, and they get, for example, a combination of fludarabine and busulfan. But what is really important is that these patients have a prolonged phase of immunosuppression, especially after allogeneic stem cell transplantation. And of course, these patients have a risk of graft versus host disease. So we have to look more in detail to these patients and look what we can do for them. So what are side effects of mucositis? What are side effects that can come? One of them are mucositis of the GI tract, and possible signs and symptoms are here the oral infections, oral ulcerations, taste changes, bleedings, pain, osteonecrosis, and diarrhea. And I would like to make a further attention to these three side effects because they are really they bring a high complication rate for the patients. So how can the side effects occur to the patients? They can be acute or chronic, so they can really come very fast and soon or more delayed. And they come with the destruction of cells, and they are not the malignant cells affected by the destruction of the cells, but also the rapidly dividing healthy cells. And they are most frequently affected the marrow cells, of course, the hair follicles, the mucosal lining of the GI tract and the skin, and the fertility and germinal cells. And here I would like to hint mostly on the mucosal lining of the GI tract and skin, because here we have the high side effect of infections that can occur to the patients. So how is the risk for infections in detail? I can say that 90% of the patients after high-dose chemotherapy and stem cell transplantations are affected by infections, and often it is a fever of unknown origin. And patients at the highest risk are those patients with an expected neutropenia phase with less than 500 neutrophils for at least 8 days or longer. And the most common infections are, when we look to the bacterial infections, invasive pneumococcal infections, clostridial and diphtheria infections. Looking to the viral infections, there are the CMV infection, the EBV infection, the varicella zoster virus infection, and the herpes simplex virus. And last but not least, there are also fungal infections like pneumocystis, Diero-Vecchi pneumonia, PJP infections, molds, mucocutaneous candidiasis of the mouth, yeast infections of the skin, and some more, but these are the most common ones. So what I think is important to look when do the infections most commonly come, and the phase is of stem cell transplantation and the occurrence of infections is divided into 3 phases. There's the pre-engraftment, then the post-engraftment phase, and the late phase. And when you look down on the slide, you see below the picture the days, day 0. The pre-engraftment is mostly from day 0 to day 15, and then the post-engraftment phase is between about day 50 to 45, and then we have a delayed time starting at day 100 about. And in the pre-engraftment phase, we have neutropenia and the barrier breakdown due to the chemotherapy, as the mucositis appears most often in this time, and we have the central venous access devices during this phase, as we need them for the chemotherapy and the stem cell transplantation. So there we have the highest risk for infections. And you see it also here on this slide that there are various infections possible and which come down in phase 2, but there the patients are still at a high risk because they have an impaired cellular and humoral immunity, and the NK cells recovers at first, and but the CD8 T cells numbers increasing, but they are restricted to the T cell repertoire. They're not so various as before transplantation. And some patients have a delay and recover slowly, maybe due to GVHD or other affections that I think they have. So I have mentioned the GVHD. Why can patients develop a GVHD? What is required for that? So the graft, the stem cells that are transplanted, they must contain immunocompetent cells that can work within the host. And the host must possess alloantigens that can be recognized as foreign by the immunocompetent cells of the graft. And the host must be unable to mount an appropriate immune response against the graft. So it's a quite complex phenomenon that comes up to the GVHD, but when I read these requirements, it was quite, for me, I could understand it better when I read it some years or some time ago. It's more easier then. So what are the risk factors for developing a GVHD? There must be or can be HLA disparity, an increasing degree of HLA mismatching. The older age of patients is a high risk factor. Then the use of female donors for male patients. To my experience, I can see that females are not preferred for donoring stem cells due to the pregnancies, because then women develop more antigens, and the prior alloimmunization of the donors, for example, due to pregnancies or prior infections. Then the nature of the GVHD prophylaxis, what has been applied to the patients for GVHD prophylaxis, then the increasing donor age also, and the increasing intensity of the preparative regimen and the use of peripheral blood stem cells as opposed to bone marrow cells. Then the seropositivity for CMV of the patients. So let's have a look on the principles of GVHD prophylaxis. We can, on one side, have an interference with the host immune response, there we have a reduction of the immune response. And here we apply a combination of calcineurin inhibitor with an anti-metabolite, for example, cyclosporin A combined with methotrexate. Or we can hint on a T-cell depletion, shortly, or the abbreviation is TCD, and there we can make it ex vivo, where there we have various methods, for example, a CD34 plus selection or the removal of specific T-cell subtypes. Or we can make it in vivo. There we apply anti-thymocyte globulins, the ATG, that is common, I think, to all of you when you're working in the practice with stem cell transplantation. So now let's have a look on the principles of early infection prophylaxis. There we should look for limiting unnecessary antibiotic exposures, then optimize antimicrobial therapies, for example, applying empirical approach when we have to escalate the antibiotics, and we have to look for catheter-related, central line associated bloodstream infections. There we have to look for sterile insertion of central venous catheters by a specialized team. Then we should avoid the femoral insertion of CVCs, as they have a higher risk for developing infections. And we should do the CVC cleaning with chlorhexidine during the use of the CVC, and remove all unnecessary catheters as soon as possible. And we have to perform regular oral care. And when we look to the catheters that are necessary, we have to look on individual problems, because we should remove the catheters as soon as possible. But when we have patients with really bad veins where we can't take the blood, we have to look for further options that we maybe can use to get the blood samples for the follow-up. So what are nursing implications? Not complications, they are nursing implications. We should frequently monitor the patients in view of vital signs and their general condition. And please pay attention to even subtle changes and address them, because it can change really fast, that the patient is in the morning really well, and in the evening the patient is already at the ICU because the situation is unstable. And in case of any infections, please have a look on monitoring the patients, intensify the monitoring, ensure the fluid balance, because they have fever and lose lots of fluids during the fever phases, and identify and monitor potential infection sites. And there have a look on the catheters that the patient has, then the mental status, signs of any bleedings, the pain, and the general appearance of well-being. Then let's have a look on key principles in oral care. There it's really important to perform an accurate assessment of the oral cavity and perform an individualized plan of care if possible, and initiate timely preventive measures and correct treatment. There I would like to go more in depth and would look for prevention of oral mucositis. And that's really important to educate and encourage the self-reporting of any oral changes, even if they are really small, these changes. But we have to look on them. And we have to look for good and regular oral hygiene, including gargling to remove any unwanted debris. Then we should encourage the patients for interdental cleaning. Then we should use fluoride toothpaste, foam, gel, and trays. Maybe also sodium chloride water or salt water rinsing. And maybe apply early nutrition interventions that doesn't appear malnutrition, that interferes with the wound healing, and maybe apply cryotherapy and sucking ice chips during melphalan infusions. And I can tell from my experience that we have in each patient room at the lavabo where the patient is washing himself and makes the tooth, the oral hygiene, we have a plan what the patient should do, when, and which things he should apply. And we have it in 3 languages, as Switzerland speaks German, French, and Italian. And we have for each language 1 paper that we can make it in the mother language of the patient, that the patient can always look what should be applied when. So an oral care assessment should include a pre-existing dental problems that should be assessed, appropriate treatments should be assessed. Older patients and females are at higher risk for oral damage. There we should have a look. Then we should look on the history of alcohol and or tobacco use. Then poor nutrition and hydration. Supportive feeding is really important, and the supportive therapies during any problematic phases like opiates, diuretics, sedatives, and oxygen therapy, which can cause drynesses. And then we should use clinical tools like a good light source, gloves, a tongue depressor, and dry gauze. And then we should make the patient in a convenient and comfortable position so he can look into the oral cavity, and we should use valid and reliable assessment instruments which are easy to interpret and which are really usable in your clinic. And then we should evaluate the oral sites, so we have the whole oral cavity where we should look like the cheeks, the lips, the soft palate, the floor of the mouth, and the tongue. And then consider oral rinses and mucosal protectants like barrier rinses that are licensed as a preventive measure and to reduce pain. Then we should perform an anti-infective prophylaxis. Maybe polypheramine is helpful for the patient, and or if possible, the low-level laser therapy. So last but not least, I would like to have a short look on the mild or moderate oral mucositis, what we should do then. Patients should be supported to continue the oral care, even when there are small damages of the oral mucositis, to prevent more infections. And the recommendation is that the frequency of oral rinsing may be increased if possible, as our aim is to keep the oral surfaces clean and moist. Then we have to check frequently for oral infections, swab and treat appropriately them. We should apply antifungal treatments, local or systematic, like it is required. Consider mucosal protectants and adjust the food intake according to the comfort of the patients. And if possible or if needed, we should monitor the patients in view of swallowing problems, malnutrition, and weight loss. And if needed, we should use artificial nutrition to avoid malnutrition. And we should assess the fluid intake and route of administration of pain relief regularly. And we should apply an adequate pain management to the patients, as it is really painful for them.
Sorry, we have 1 minute left.
I'm 2 sentences and I'm finished.
Okay.
And we should educate our patients in view of reporting us any changes. So here are my references for the presentation, and thank you very much for giving me the opportunity to talk here, and I wish you a pleasant day.